Thank you, Chairman, and thank you for inviting me to present my talk here. So my talk is about the mitral TEER, which is mitral clip and recently Pascal, and how to deal with the large gap. Well, as you know, the history of mitral TEER is starting from the mitral clip, and also it starts from the surgical edge-to-edge repair that was first done in 1991. And that was converted into a transcatheter repair treatment, and the mitral clip was first applied to the human in 2003. Later on, in Europe and United States, and also in Japan, started the clinical trial, and we were lucky to have first Japanese case in our institution. He was done in 88 years old and lived for 6 years afterwards, and did really well afterwards. In 2018, PMDA approved, and we have started the mitral clip therapy. The number of the mitral clip therapy in Japan has gone up over 10,000 cases, and most of them are a secondary MR, knowing that this procedure is not just the valvular heart disease treatment, but also the heart failure treatment. As you all know, mitral regurgitation is divided into primary and secondary MR. And for mitral clip, in primary MR, TEER is indicated for only for high-risk patient. And the secondary MR, medical refractory heart failure patient requires the mitral TEER. The device improvement also had a strong impact on the outcome and also the MR reduction. In a recent year, post-MR after mitral clip, less than 1+ was about 53%, but in a recent report from the EXPAND G4, mitral regurgitation less than 1+ went up to 91%, and more than 3+ is less than, it's about 2%. So it's remarkably improving the result of the mitral regurgitation. However, there exists anatomical suitability for the MTEER that has been shown, and easy case is a P2 segment and no calcification, small width and small gap. When it comes to a multiple, like severe valvular disease, it's less likely to get the success, and intermediate risk is observed, which includes the large flare gap, which we're going to debate today. So what is the tips and tricks for dealing with the large gap with MTEER? I think the procedure management is very important for those patients with, especially in the functional MR. Unloading of LV size, LV is very important to stabilize the hemodynamical state. And also, doing the right heart catheterization is very useful to see how the condition is. And maybe from this, you might need to use the inotrope before this procedure. And also, we really have to care about the LV dysfunction, not only for the LV, because after the procedure, some patients do produce LV dysfunction due to the iatrogenic ISD. During the procedure, we have to care for the cardiogenic shock when there is a severe LV dysfunction, also LV dysfunction, by doing the general anesthesia. And as already has presented, PEEP can be really, has a really impact on reducing the preload and may shorten the gap. Independent grasping also is one procedural technique, but I personally don't rely on this independent grasping because it's forcing the leaflet too much and can create the SLDA. Multiple clips recently has gone down, and but the angioplasty effect is enormously can be seen using multiple clips. So this can be really important, and 3D MPR is useful as well. So I'm going to highlight on some of the presenting with some of the cases. First, the appropriate use of inotrope. This is a 53 years old male. He had multiple times of acute decompensated heart failure, total of eight times. And he had done all the guideline medical therapy, but he has severe symptom with NIHA class 3. As you can see, this is the echo in a worsening state. There's a big gap between the tip of the mitral valve, and see the massive MR coming towards the left atrium. Notice that the size of the LV is 82/76, which is not the co-opt trial indication. So it can be 2B class indication for the TEER. However, if you look at the hemodynamics, with the right heart catheter, high wedge and high PA pressure can be observed, and with really reduced cardiac index with a 0.9. We are dealing with a lot of severe LV dysfunction case to do the TEER, but as you can see, this is the old case in our institute, and cardiac index is located in most of the cases about 2.1 to 2.5, but this case is the lowest cardiac index in our center. The vitamin 4 gamma was started, and congestion get better after the 2 weeks. And we discussed with the surgeon, but the surgeon didn't want to do the surgery. Other than that, transplantation might be the choice, but he refused transplantation, so we have to go to TEER for this patient. As you can see, the gap has gone down after the after the dobutamine was initiated, but still there is a gap in the center, still massive MR was there, and quarter free zone was 8 millimeter, annual size was big, and there's enough fossa distance. So we went to the mitral clip. First clip was implanted in the just medial side of the center leaflet, and you notice that the severe reduction in MR, but still there is a minimal MR on the left lateral side, so we placed another clip onto the lateral side. And MR was reduced to mild state after the placing 2 clip. Notice that the right heart catheterization pre and post mitral clip, wedge pressure and PA pressure went down significantly, and also cardiac index went up from 1.5 to 2.5. And this is the 6 months after the mitral clip, and you can appreciate the reduction of the mitral regurgitation. Also, his symptom significantly improved, even though his LV size is a non-co-opt patient. Second point is that the multiple clip foraminoplasty effect. This is our Japanese registry, Ocean Mitral Registry, that I'm included as well. We have published a paper showing that the number of the clips has went down about 10% from G2 to G4. That's because we could select the longer and wider clip. Average is went down from 1.46 to 1.3. And when we look at in our institution with a total number of 230, we can clearly see the number of the clip when from G2 to G4, especially in a ventricular and atrial function MR. However, the number of the clip did not change even after the G4 in DMR. So most of the case, we deal with 1 clip in ventricular function MR, but there are some cases you need a 2 clip even in ventricular function MR. For instance, this patient have severe mitral regurgitation from the middle to the medial side. However, the mitral valve area is 3.4. It's very small mitral valve area. And also the PMN length was 8 millimeters. So we cannot use longer device. We cannot use we couldn't select the 2 clips. So we selected NTW to reduce the MR. hoping that the MR is gone, only with NTW, because that was the only choice that we could choose. So one clip was placed in the center of the mitral regurgitation, but even grasping, there is no change in MR. And we made a lot of try to shift it towards the medial side. We did a lot of things using a PEEP as well, but there's no other way that we can reduce the mitral regurgitation with only one clip. So we have to leave this clip for the first clip, and MR can be seen from both sides of the clip, mainly from the medial side, but still there's a lot of regurgitation on the lateral side. And this was first implanted was my colleague, and he was saying, oh no, what are we gonna do? Because the MVA was 3.4 millisquared. So I changed, implanted was changed to me, and I placed the NT clip just besides the NTW for the second clip, to reduce as maximum as possible in the medial side. And acceptably, we didn't expect this result, but the MR and the medial side reduced, but also the lateral side reduced as well, and the MR got trivial after 2 clips. So this is the first echo, and you can see the AP length before and after has significantly changed. And I think this is because the second clip has made an small annular plasty effect. And this has been shown by the paper also, that the annular dilatation annular reduction have a negative effect on the MR reduction also. So I think this is a very important point on the functional MR when we have a large gap, not to leave clip, not to leave the MR. Lastly, I would like to show the 3D MPR method to do with a primary MR. This is the 90-year-old female who has a symptom of DOE, but she's really active patient, and she is actually a professional musician playing piano until 89 years old. But she complained of dyspnea, and she was transferred to our hospital. And you can see a massive MR, and also MR was coming from medial side of the posterior leaflet. As you can appreciate, there's another P1 segment, a bit billowing on the side, but the major MR was coming from P3 segment. So how do we deal with this patient? If we cut with the normal biplane X-plane method, then the LVOT view is shown in this yellow line. But the MR jet is going from the medial side to the anterior commissure, about the 10 degrees, or 10 o'clock direction. So we wanted to cut into this direction to see the grasping angle. So we used the MPR method to get this kind of angle. MPR method can easily set the angle by rotating this, this line in a short axis view, showing the left side, left bottom side. If we rotate, if you pinch the line of green, then the green box would show you the grasping angle, and also you can set the orthogonal plane to the grasping angle on the red box. That can allow you to guide the clip even during the procedure. And we use this method in live 3D MPR method and in a complicated DMR patient. So we placed the long XT device to this patient. using NPR method. And the MR significantly reduced to mild or trivial. And this is pre and post TEE. So this can be very useful in challenging DMR cases. For instance, in a non-central MR, we can see multiple regurgitation from the medial side. We place the 2 clip into this patient. Another is very complicated anatomy, bowel disease patient. We also see the MR jet in the multiple plane using NPR, and 2 clip was also placed. And then reduction was significant. So my take-home message, as TEER cases increase, there are more challenging cases to treat. In severely reduced LV function patient, inotropic drugs for stabilizing hemodynamically is necessary to allow safe procedure, and also the live 3D image is useful tool for complex anatomy. Thank you very much.